And so one of the challenges, and we don't know where we're going to go. We're waiting for the results of the field trials. It's possible that we might say, 7 dimensions, not useful, not practical. Basically, let's simplify this to 4, if you will. I mean, we'll all think that depression certainly needs to be assessed separately. We'll all agree that reality distortion needs to be assessed separately. Mania, perhaps. Psychomotor symptoms, perhaps. Cognition, yeah, but what's the utility? Are there specific treatments we have for cognitive deficits in schizophrenia? Although we know that it's a very important element of prognosis, what happens, how well patients do. The other problem with each of these dimensions, and this was the challenge, that the experts out there in each of these would say, what do you mean impaired cognition? Cognition is multidimensional. There are at least 6 or 7 important relevant domains of cognition. How do you combine them? Reality distortion, that's ridiculous. Delusions and hallucinations are different. Measure them separately. The problem with that approach is we'd have had about 25 dimensions instead of the 7 that we're currently field testing.
Like support functioning, self-care.
That's so ultimately, obviously, what you really want is how well patients are doing. But in terms of the impact of our treatments, what they impact are these psychopathological dimensions, and the other thing that they impact is side effects, which also affect quality of life and functioning, if you will. But in terms of looking at the impact of treatment, these dimensions, these are also valuable from a research perspective, if you will, as we try to better understand. One of the challenges we have is we have the diagnostic system we do. We can't discard it. We've lived with it. We function by it. We practice clinical work. We do research by it. And so one of the challenges is you can't say, okay, that's imperfect. Let's start off from square one. We're not starting off from square one. So the challenge is, how do we bridge from my generation or the generation before me to Dr. Sen's generation, which is, down the road, next generation, we're going to be, hopefully, have biological markers. We're going to have diagnostic tests. We're going to define categories based on understood pathophysiological mechanisms. How do we make that bridge? And we felt this was a way of bridging to endophenotypes, if you will. But I'll spare you the detail there. But this is one thing that is being field tested. Essentially, we don't have a category of attenuated psychotic symptom syndrome. Now it's the attenuated psychosis syndrome. The name is likely to change again because this name is considered unsatisfactory. But bottom line is, if you have attenuated psychotic symptoms, delusions, hallucinations, disorganized speech, those are 3 criteria that we consider to be core psychotic symptoms per se. If you have one of these in attenuated form, and we define what that is, and they're present for a sufficient amount of time, they progress over a period of 3 months, and they are associated with distress, disability, and/or treatment seeking, then essentially, and you've never met criteria for schizophrenia or other core psychotic disorder, then you have the attenuated psychosis syndrome. So there are all these features in there, and this is being field tested. Quite candidly, if our work group was to vote on this right now, we would not support its inclusion. There are some people in our work group who very strongly believe that it's ready for prime time. The majority of people in our work group believe, it should not be in the main text. It may be in the appendix, if you will, as a condition for further research and study. Because it's important, but there are all sorts of challenges with this category as well. Because you'll identify a lot of false positives. There's the concern about, so are a lot of people going to be inappropriately treated when what they really need is watchful waiting and closer clinical monitoring, for example. So there are issues there. Schizoaffective disorder, everyone's favorite. Does any of you diagnose schizoaffective disorder? Have you diagnosed schizoaffective disorder in the last year? A very, very important reason why people diagnose schizoaffective, A, you're not sure, or you see elements of both. You want to give them the benefit of both, if you will. And the benefit of both, and in some formularies and things of that sort, if you've got a bipolar disorder, you cannot get certain antipsychotics, so you've got that particular constraint as well. So I went into this, I mean, I've been involved in this process now for the last 4+ years, thinking, you know, I want to get rid of this diagnosis because it's used for multiple different purposes, and what you call schizoaffective might be very different from what I call schizoaffective. Actually, what I call schizoaffective one day might be very different from what I call schizoaffective the next day. I mean, it really is not particularly meaningful. It's got lots of different meanings. In any case, this is a challenge. You know, you've got psychosis and you've got mood. So how much psychosis relative to mood makes it schizoaffective versus schizophrenia with some mood symptoms versus psychotic mood disorder? How much overlap? And what's the pattern of overlap, if you will? And this is what we've proposed, okay? So schizoaffective disorder is going to be retained, but we try and define the boundaries between that and psychotic bipolar disorder, and that, and we use the DIGS definition to a certain extent, but we make it clinically more useful in our minds. And we clearly state that schizoaffective disorder is not an episode diagnosis. It's based on a lifetime course, if you will. It's a lifetime diagnosis. And it's being field tested. So we'll see how this pans out.
Would you read C? Because
I'm sorry, I apologize. It's a major mood episode is present for the majority, more than 50%, of the total duration of the illness. Note periods of successfully treated mood symptoms count towards the cumulative duration of the mood episode. We're using a very high, I mean 50%, DIGS is 30%, if you will. And so this is 50%, and you know, again, it's being field tested, we'll see. One of the challenges was, you want to keep the diagnostic system simple as possible. The more complex you make it, it's going to be even more difficult to use. Clinicians are not going to use it. The second thing is it an episode-based thing, or is it a lifetime-based thing? I mean, that was one of the big conceptual discussions we had. So when you talk about periods in remission, if we're going to look at lifetime, the question here was, is it 50% of the period you spend in psychosis or 50% of your total duration? And so that's why we said 50% of the total duration. The assumption is you already have psychosis. See, because that's the lead-in. It's an uninterrupted period of illness during which time you meet criteria A for schizophrenia. So you have psychosis. And of course, part of criterion A is that you, successfully treated positive symptoms count towards that total period of criterion A. It's not perfect. Let me, Dr. Constantine's going to yank me off, and I haven't even gotten to the part of the presentation I was supposed to deliver. So this is a timeline, and right now, there's a lot of the Board of Trustees and the AP Assembly have their own review panels which review all these revisions. Let's get to treatment. This is the issue in terms of treatments. This is what we want. You've got this illness that makes it difficult for people to lead productive, meaningful lives. And the ultimate objective is to help them lead meaningful, productive lives. And the way to do it in schizophrenia is to do one of three things: treat them, reduce the symptoms, get rid of the symptoms, help them work around some symptoms, and provide supports around them so that they can function as effectively as possible with who they are. So the idea is to reduce the burden of the disease while adding as little treatment burden as possible. And the fact of the matter is, no matter what we do, whether it's psychotherapy, whether it's medications, whatever it is, there is a treatment burden that we add. And so the critical thing is reduce the disease burden while adding as little treatment burden. And these are, when we think about, so what are we doing in terms of treating schizophrenia, this is what we're targeting. This is the nature of the illness that we need to be cognizant of as we treat. Multiple dimensions, distinct stages, as all of you have pointed out, the fact it's characterized by acute, repeat psychotic episodes, and relapse. The remissions are incomplete, and this is recurrent. So relapse prevention becomes very, very, very important. And these are some of the treatment challenges. The treatments we have are only partly effective, and this is a really important fact and tragedy of schizophrenia, and Dr. Newcomer is going to highlight this in his presentation, I'm pretty sure. People with schizophrenia on average live about 15 to 25 years less than the general population. And the gap has been increasing over the last 30 years. It's a tragedy, a fact that we just need to kind of be mindful of. Why is the gap increasing? Is it the illness? Is it things that happen with the illness, obesity, things like that, diabetes? Is it treatment? Is it lack of care, that persons with schizophrenia get poorer care than the general population? And the answer is there are elements of all of the above. All those factors are relevant. It's not one or the other. That we just need to be cognizant of that fact, if you will. Antipsychotics are the mainstay, and this is really the bridge to our discussion today. They're the mainstay, and they do two very important things in schizophrenia. One, they're useful in treating acute psychotic episodes. And two, they're very important in preventing relapses. And while all of us pay a lot of attention to this, and this is important, this is at least as important, because relapses are bad. Relapses are bad for the patient because not only is the acute episode during a relapse bad because you have more distress, increased risk of suicide, aggressive behavior, increased vocational social disruption, increased costs of care, but along with each relapse, subsequent recovery becomes less complete. Patients don't return to where they were prior to that relapse. The illness becomes more resistant to treatment, and regaining prior function becomes difficult. And so critical that this is important, and as is relapse prevention important. So, well, how do antipsychotics agents compare? Let me actually pose a question here, and let's just take a vote. We've got 20 people in this room, and how many antipsychotic agents are there in the world? 25. How many of you vote for 25? Not 25, 35. 1, 2, 3, 4, 5, 6. It's a scientific poll here. Okay, 45. 1, 2. Marie, is that a yes or a no?
No, I voted for 35.
You voted for 35, okay. You can vote twice. I mean, yeah, this is Chicago. So we've got two, okay, so 2 for 45. 55. 1, 2, 3, okay. 65. 1, 2 for 65. 75. No, 65 is the right answer. There are 65 agents. Okay, well, the next question. How many of them are available in the US? And the answers range from 10 to 25. And the answer is, it's 20. These are the ones we have. And 10 of these are so-called first-generation antipsychotics, and 10 of these are so-called second-generation antipsychotics. By the way, you know, one of the papers that you have in your materials actually contains the name of all these 65 agents that we have. The only 3 that are not contained are the 3 agents that were introduced since 2009. Iloperidone, acenapine, and lurasidone have become available. Actually, at our last meeting, iloperidone and acenapine had been introduced, but there were questions about them which were reflected in our guidelines itself. Lurasidone has just become available. So these 3 agents you could add to the list of 62 that you have. But this is the way we understand them. Typical, atypical. And this is what we thought atypicals did. If you recall, this is the slide that we discussed in 2005 before the results of Katie came out. It was July 2005 that I think we met. And we essentially said, you know, basically if you look at these different medications, atypicals are better because they do all these different things. They're better for cognition, they're better for depression, they work in refractory patients, less TD, less EPS, better for negative symptoms. So that's the reason. In our first version of the adult guidelines, we said use atypicals first, other than clozapine. That was the first level in terms of the guidelines. And since then, there have been a spate of studies, a lot of data analyses, lots of reviews. And the question is, are they really better? And if they're not different in efficacy, are they really better even in side effects? What about their own side effects, the metabolic side effects? Are they not at least as bad, if not worse, than EPS? Things of that sort. So those are the questions that have been raised. And this is one of the papers you have in your materials. This was a statement of the World Psychiatric Association Pharmacopsychiatry section came out with to address some of these questions, if you will. And these are the bottom lines. And all experts would agree on this. The important thing, though, is do all of us clinicians, we're the true experts, do we believe in this, and how do we think about this? All antipsychotics are effective against psychotic symptoms. Each medication has unique side effects. Each medication has unique pharmacokinetics, and different patients respond preferentially to different medications. Clozapine is more effective, at least that's what the data suggests, than other agents in otherwise neuroleptic antipsychotic refractory schizophrenic patients. None of the other 64 antipsychotic agents share that particular property of clozapine. Some are suggested to have a little bit of it, others not, others not at all, but none of them are completely clozapine-like. Very important, EPS avoidance while getting a good antipsychotic effect is very, very important, because that is what helps. You get a good antipsychotic effect, you avoid EPS, you don't have to use an anticholinergic. That's the property that leads to benefits in negative symptoms, cognitive symptoms, mood symptoms, as also the low risk of tardive dyskinesia. And of course, minimizing metabolic side effects is very, very important.